The second speaker for the day is Dr. K. Mohan. He is the director of MK Nursing Home since 2000. And we all know about MK Nursing Home, which is situated at North Madras. And when we were students in the 1975s and 80s, we used to work there for the evening to get a lot of experience in general practice. I hope most of them remember that. And he had his undergraduation at Ramaya Medical College in 1985 to 95, and he did his general medicine at Rajiv Gandhi University, Bangalore, under the same college. And he did specialized in a PG diploma in diabetes at Newcastle University, Australia, in 2005. He has been having a lot of professional activities, especially in the field of diabetology. He is the facilitator in the Department of Diabetology, Distant Education in Annamalai University since 2005. And from the MJ University, the prestigious MJ University in 2013, he has been a regular course facilitator for a number of years. He has been a speaker in various forums, including Indian Medical Association, North Chennai Madras Association, conducted 6 All India Diabetes Conference in Chennai between 2006 and 2012, elected as Secretary of North Chennai Doctors Association for the last 2 years, and he is also a core committee member of the certificate course in diabetology in MJ University. So he has been in various association members. One of this is API, Indian Medical Association, and member of Diabetic Association, sir. Sir, welcome, sir, for your talk today. Thank you, sir.
Thank you for the kind introduction. I met Dr. Kailash sir when I finished my MBBS. We used to have a certificate called as FRS, Forest Judgment. It's been a long association. Thank you for giving me this opportunity to be in front of you. It's a vast topic. Of the 5 topics given to me, I'm not presenting IET because I thought it will be too overwhelming. So I'm covering the other 4 topics, which generally fall in behind obesity basically. Let me start with the topic. The topic is, the first topic is about obesity. So obesity comes from the word obesus, which means that fat, plump, or it is clinically defined as a BMI of more than 30. In India, we can say more than 26 can be taken as overweight. But then the problem with BMI, as I will again we are referring to, is that it could be fat, it could be fluid, it could be muscle mass, bone, tumor. Any of those things can increase your overall weight. The incidence is more in women than in men. And Tamil Nadu is quite up on the chart because it's doing very well. If you look at it, Tamil Nadu, Kerala, it's all up on the chart because it's doing very well. Basically, obesity results from higher energy intake, which is more easily available as the kind of lifestyle goes up, and less expenditure, which is what we have worked on for the past century. Typically, as they say, the cause of, whenever you talk about the cause of obesity is this. There is an inheritance, the thing, but it's not a mandatory inheritance. There is a genetic component to it, no doubt. Some people do have other diseases which can cause secondary obesity. That said, they are all very small in number. The major cause for the obesity is what the joke says. It's not that obesity runs in the family, it's because nobody in the family runs. That's the reason they are obese. It is a heterogeneous group of disorders where I said the mixed bag between intake versus expenditure is there. And the clustering in families occur because usually the way they eat and this thing is always together. And not only that, the childhood obesity is increasing in an alarming rate because of literally for one reason, availability. Very easily things are available to eat. Obesity by itself can cause 2-3 things. One is sleep apnea. Other is it can cause gallbladder disease. We typically talk about that fatty 40, like that, like gallbladder disease. And by itself it can cause breathlessness. Other thing, it increases the risk of diabetes, hypertension, dyslipidemia, insulin resistance. To some relative extent, it increases the osteoarthritis, gout, hyperuricemia, and coronary heart disease. To a small extent, it increases insulin resistance, impacts fertility, polycystic ovarian syndrome, reproductive hormone abnormalities, cancer, and low back pain. But that said, the fact that obesity increases or impairs fertility is a very funny thing. Because if you see the Roman gods and goddesses of fertility, it was always a huge compared to the thing. But later, what we are finding out is that whenever there is a famine, the natural thing takes care of it, that there's more fertility in such places. Regulation of appetite, I'll not be dwelling too much on it. We need to remember that the hypothalamus plays a huge role, and the leptin and ghrelin, which are two identified hormones which causes the satiety and the thing. On the opposite side, melanocortin is very important because the sleep-wake cycle is one of the reasons why satiety is lost. People overeat or the thing according to how they work. The arcuate nucleus contains two distinct groups of neurons, and they stimulate feeding and inhibit satiety. This is very important because one of the central components for not having satiety is loss of this feedback. And the feedback is something which is trained. You can train. That is the difference. The measurement of obesity is very important. The BMI, waist-hip ratio, and other things are there, of which, in terms of normal day-to-day thing, BMI is used as an index to measure. Waist-hip ratio or just the waist circumference is the easiest way of measurement, but for documentation, BMI is better. In terms of DEXA and MRI, it is purely a research tool because that is the only thing which differentiates the brown or the good fat from the white, which is the bad fat. The Indian BMI, when we were talking about BMI in 2000, we used to say like 50% of Indians fall below this 18.5. We used to make fun. But now what we realize that more than 60% fall above the 26. The cutoff in India is 26. This is still important because you need to be above 40 or grade 3 for them to be suggested any bariatric surgery. So for that, this is an important way of this. But that said, the minus point with BMI is that it is the weight divided by height in meter square. So if you are unusually tall, unusually short, your weight could be again fat, could be a bone mass, could be an filarial leg, could be fluid. All those things also interact with your weight. So this does not differentiate any of these things. That's why though BMI is a very easy index for us to write or document, it is not the best way to say somebody is obese. Easier way is to just measure the hip measurement or the waist-hip ratio. Waist-hip ratio is a little more difficult, whereas hip measurement is much easy. For the hip measurement, women of less than 88 centimeters are at decreased risk, and men below 100 centimeters are decreased risk. Anybody above that, they are at a higher risk. So when you look at it in terms of risk stratification, it is easier to use just a tape. It is much easier to do this thing. For documentation, BMI is necessary because it is universally followed. Because here in terms of the waist measurement alone, the biggest problem is where you have measured it. It could be 1 inch above the umbilical, just around. So the standardization is much lesser. That is the reason BMI is still followed. Biometric impedance has been coming in lot of, there are a lot of weighing scales where you can use biometric impedance. It is scientifically right, but practically there are so many things which do go wrong. So many of the weight reducing complexes that we have, they use these sort of things to tell them that so much of fat you have, so much of electrolyte imbalance you have, and start correcting it. It is clearly not scientifically taken for a day-to-day utility. CT-MRI, as I told you, is an important research tool for differentiating between the good and bad fat. Generally, the android type of fat or the midgut fat is meant to be bad. That in around the hip and buttock or the gynecoid type of fat is meant to be better. The brown fat is meant to be better. Coming to management, we all understand it's a chronic medical condition. We need to attain normal weight should be a long-term goal, but short-term goal would be just reduction of 10% of the starting weight should be a short-term goal. Sustain 10% itself is a very, very difficult goal. And all the treatments that we have seen or we are going to see or have their own side effects. In clinical practice, very, very difficult to achieve and sustain this sort of a thing. I'm sorry about the busy slide, but basic of anybody having an BMI of more than 30, you need to understand that we are treating.
It's not clear.
Sorry? I mean,
No, slide's not.
oh, this slide is not, it's too, that is messy. Basically, we need to understand that the blood, we are trying to decrease the mortality of that person. So, the blood pressure, glycemic targets, cholesterol targets, liver function, suppressive sleep apnea are the things you should target and treat as you are treating obesity also. Per se, you are reducing obesity to avoid them from falling sick due to these things. As I already alluded to, just reduction of 10% of your sustaining a 10% reduction of body weight is good enough to decrease mortality by around 40%. It also helps with reducing blood pressure, diabetes and lipid goals. But sustaining this is the biggest problem. Lifestyle modification is the most important thing. We should understand that we can have a low calorie diet, but when you have a low calorie diet, the composition of diet does not change. Everything including vegetables have carbohydrates. So we need a low calorie, low saturated in fat or low saturated fat diet. Normal protein intake, I'll come to the proteins again, but with increased fiber because satiety is the major problem which nobody adheres to in a diet. You can calculate the diet by using another thing. The basal metabolic rate is calculated from which you can, the number of calories needed for a sedentary person would be BMR into 1.2, whereas an active person would be 1.7, would be the calculating other thing. We should understand that no matter what is the calorie diet you are giving, the composition remains the same. That's what. You reduce the rice, let us say, but you replace it with vegetables. You are still giving carbohydrates. So the carbohydrate amount is still 55%. Fat is 30%, protein is 15%. This is very important because you need sustained slow weight loss. Sudden weight loss usually springs back to and higher level than normal once you go back. Very low calorie diet has been proposed. Again I said the composition doesn't change. 400 to 600 calorie diet has been tried, but rarely should be used more than 2 months because the complications of fatigue, hair loss, dry skin, dizziness, difficulty in concentration, choleric acid, pancreatitis, gallstone, and even sudden death have increased due to that. So this is not to be done unless you are every day in contact with an dietitian. And high protein diet, again, this has been shown to cause life-threatening arrhythmias. So it has been dropped in some countries. There is a lot of flake about it. There's a group which says that high protein diet is alright. I think a short jump to start weight loss is fine. But any of this thing to be continued on a long-term basis would not be right. Physical activity is the only thing which has been shown to be always useful because it not only reduces weight, it also improves all the other things like your own self-confidence, it decreases anxiety, depression, and it causes better sleep, decreases sleep apnea. This is the only thing which is shown to be persistently useful in so many ways. Pharmacotherapy, there is a lot of drugs which have come in and gone. But what we have realized is that the older drugs had a lot of serious side effects, so they were dropped. Next came sibutramine, which was there for a long time, which is still available basically, but there also at least it is contraindicated in coronary heart disease patients because it increases arrhythmias. Orlistat is there, which is still available, useful, quite safe. But the problem is you purge a very oily stool, which is very, very inconvenient. In fact, people who use it say like they are unable to hold their stools. That is the problem. The thing, not very effective also. For all the trouble and cost, it's not been very effective also. That's the reason it's not been so popular. Metformin in children have been used with the thing for in adults. It's around 1 to 2 kg weight loss has been documented, which may not really make much of a difference. These are not yet available, but these have been talked about for a long time. GLP-1 analogs are there, which have been now accepted as a weight loss agent. Also, there's the thing. Good amount of weight loss can be achieved with such the thing. Bariatric surgery is the last resort if the BMI is above 40, or if a patient has other comorbidities which are rising very high, then you possibly try to offer them the thing. There are two types of procedures: the more absorptive procedures like this, the bypass, the jejunal bypass, the roll-in operation that we hear of is that, and the restrictive procedures like placing a band or putting in a balloon inside. These are quite safe because it can be basically these are reversible surgery, so these are comparatively safer. That said, when they have a complication including death, 1% death can occur with these procedures. So, like it needs to be taken with a pinch of salt. That said, in morbidly obese patient, there's a chance of sudden death with somewhere around 8%. Chance of diabetes related, cardiac related thing is around 40%. That said, this 1% is still a very good choice we are taking. Going to the next thing, the GERD or the gastroesophageal reflux disease. Any symptom or esophageal mucosal damage that results from reflux of gastric acid into the esophagus is called as GERD. GER or the esophageal reflux is normal, but when the disease has become, when there's a heartburn, it causes trouble. Symptoms can be esophageal or non-esophageal or extraesophageal. The esophageal symptoms could be symptomatic syndrome, that typical reflux syndrome or chest pain syndrome. Or it can be with esophageal injury like the Barrett's esophagitis, reflux esophagitis causing stricture, Barrett's esophagus, and esophageal adenocarcinoma. The extraesophageal symptoms are equally important. The cough-like syndrome, asthma-like syndrome, and reflux laryngitis, reflux dental erosion have all been noted, which are quite common, and these are established associations. Pharyngitis, sinusitis, and recurrent otitis media are proposed associations, which are occasionally seen to be kept in mind. Many patients come with different way of expression when it comes to GERD. The commonest is like they feel a water brat they come with. But that said, it may not always be. People come with chest pain, people come with a heartburn, people come with an irritation in the upper part of stomach, people come with even just increased amount of spitting. So many patients present with a very many different type of presentations which needs to be understood. All of them could be indicative of anything from a normal thing to mild severe esophageal to cancer. The normal physiology is that the clearance mechanism, including mastication, is very important to prevent reflux. Followed by the mucosal integrity, the strength of the lower esophageal sphincter, and the emptying time. The pathogenesis can occur due to decreased salivation, decreased mastication, impaired tissue resistance, or due to hyperthermia, decreased ileus tone, delayed gastric emptying. It can also occur due to, we should understand that it is not, the contents is not only acid, but also has bile and pepsin along with it. It could also be due to that. When do you think of a complicated GERD? Is when there is a dysphagia or real swallowing difficulty is there that could indicate a stricture, odophania or rectosternal pain when swallowing, or bleeding occurs. General GERD does not need any big studies before you start treatment. Only complicated GERD or resistant GERD needs the same. But when do you do diagnosis tests? When there are multiple symptoms involved, when there are atypical symptoms involved, symptom associated with complications like we talked about, inadequate response to therapy of at least 1 month in duration, and prior to anti-reflux surgery. Treatment goal for GERD is to eliminate symptoms. That is the major thing. They come for the symptoms basically. Prevent esophagitis or heal esophagitis if it's there. Manage or prevent complication and maintain a remission. Lifestyle modification is typical. Like ma'am already alluded to, we try to have their head slightly raised so that it doesn't come back. You can avoid eating 2 to 3 hours before bedtime. Lose weight, which is very important. Stop smoking, alcohol consumption, which are very important. Less fatty diet. We were always worried about hurry, curry, burry. But now we should understand that the curry is not the cause. It's the oil in the curry which is the cause. That causes the least filter to the thing. So decrease the oil amount in the thing. Few things is the chocolate, oil in the chocolate, and beverages like carbonated beverages which can easily regurgitate. And OTC medications including NSAIDs are important factors. These are age-old drugs we've been using, like all of us and including our seniors would have seen every surgery posting would have had multiple open surgeries which are totally we stopped doing with the intent of proton pump inhibitors. But unfortunately for the past 2 years we've been hearing that proton pump inhibitors increase both MIs and renal dysfunction. So it is now very clear that we are not supposed to use the proton pump inhibitor for more than 3 months. If possible, step down or give alternate therapy. Not to use it continuously for more than 3 months and not to use it more than twice a year for more than 3 months.
Patients use it continuously.
For us, everything is OTC available now.
But there is renal dysfunction really noticed in
Yes, very clearly documented.
because there was
I asked a nephrologist, in fact, like my brother was a nephrologist in UK, like he sent me papers because I asked for specifically because this looks, we've been using it for years, literally for the past 10-20 years we've been using it. We have not seen, we have not been at least correlating it directly, and sir is saying like a lot of patients use it lifelong. Even one day you stop it, they come back with a complaint.
For 10 years. But what to do in such cases? One day we stop the
For that, sir, reflex, I will come to that, sir.
But actually what happens is if you use a proton pump, acid in the stomach will come down, which will cause
Why is it will cause infection? Yes. Because it goes to achloride, almost 8, because proton pumps are so thing.
Is it okay to use it whenever we have symptoms?
I think so. What they say is that less than the dictum, general dictum when we ask the thing for generalization, headache, pain abdomen, GERD, if you can use it for less than 4 days a month, I think it is within control is what they say. Generally, that seems to be the okay, yeah. This is you need to use a PPA at least 15 minutes before the bedtime. It takes around half an hour for it to act, so you need to use it earlier. Maybe if you are using an PPA with the prokaryotic, it needs to be much earlier. And you can sometimes in all patients, though rabeprazole is meant to be the most renal and cardiac safe, sometimes switching of proton pump inhibitor works in some people. We still don't know why. In some people, switching off proton PPA seem to work. Another thing which people do is that if they are still, I think that's right. Yeah, it's a relapsing condition. When most patients, 80% of the patients, it relapses within 6 months. What they say is that minimum 3 months gap between the thing you can use an head to receptor antagonist in those periods. The current RAF technology, the thing is very useful in preventing refluxes. So during bedtime, you can use those sort of liquids and liquid antacid with the RAF technology, and use because the acid alone is not a thing. The entire thing, when you lie down because of obesity and the thing, regurgitation is a major problem. So you can use that more liberally in between, and then come back to BP after 3 months is what they say. Immediately after eating, not to sleep. That's the very, very important part. And they say it's better not exercise also during that time.
Yeah.
You take a much slower pace thing.
Sucrafil is recommended. Sucrafil is a
Sucrafil is a very good, for ulcer healing, alginate and sucrafil are very good, man. Whereas the alginate draft is good for prevention of regurgitation. So,
Gaviscon is the wrap.
Gaviscon is the
Gaviscon is the
draft.
wrap.
Yes. Instead of Gaviscon.
Gaviscon is the wrap form. But that has to be taken after food.
That has to be taken after food. Whereas sucralfate and all is for ulcer healing to be taken empty stomach.
And pantoprazole also to be taken before food.
Before food. Before food. The older with an anesthetic agent like mucin, trichine, all those things, that is to be taken just 5 minutes before food. So that as the acid comes down, it is dissolved.
But they say don't mix antacids with the proton pump.
Proton pump inhibitor. Yes. Complications of GERD, erosive ulcerative esophagitis, and esophageal stricture are common. Luckily, adenocarcinoma, Barrett's esophagitis in our situation seems to be much lesser. For anti-reflux surgery, the main thing is fundoplication and correction of hiatus hernia, 2 things which can look at which could help people. And other things are there where you can push in, there are surgeries where you can push in to increase the lower esophageal sphincter. Through an endoscope, a glue like this thing can be injected. There's a heat coil which can put up which increases the thing. Those sort of things.
Are there any drugs which will increase GERD? Not drugs, food that can increase GERD.
They say anything, it's it's not subsisting by itself. Oil, chocolate, the oil and chocolate.
Sometimes the sweets, cheese sweets.
Fat again, man. The fat which is the main thing. Chocolate because they contain chocolate oil, the cocoa oil.
That means curd also can increase.
Curd also can increase it. Curd, we always feel that after it decreases everything, but if it is a fat, it's a fatty curd, it can increase it. Okay, again a busy slide, sorry, but this is the general diagnosis and treatment goes like this. Patient with a heartburn, initiate with an H2RI. If they are alright, taken twice a day, good response is there, then you can leave it at that. If not, see if there are relapses, multiple relapses, then go for a PPA. PPA works, again alright. If not, go for twice a day divided dose of the PPA, not a double dose, not along with domperidone, again double dose. But a divided dose of the PPA or one PPA with an H2RA in the night. And if there's a good response, is fine. If the symptoms are not there, then consider screening for other things. Their manometry, all those things are become very important.
The combination.
So 80 milligram has come now.
It's just for a short 1 week course.
1 week.
1 week course. So, some people do not respond. In fact, I'm sorry to say, few companies have come with a very sustained release form of the thing. Like there's a DSR, macrobonic DSR, there's a thing. Just maintain the same amount of the thing for 24 hours. Sorry to use a generic name because the thing 24 hours sustains with the same thing. So once a day dosage gives a better relief.
But combination with domperidone and zinc routinely should not be used.
Routinely can be used for a short term. Esophageal, extraesophageal manifestation of GERD, laryngitis, asthma, cough, again same thing. If symptoms persist, then you should try for this thing, have a trial PPA for 3 to 4 months. If there is no response, then think of other reasons. If there is a response, do therapy taper. And this is what we were talking about. Basically, the management is lifestyle, food, alcohol, caffeine, nicotine, those sort of things need to be avoided. Eating late, at least minimum 2 hours gap should be there between your bedtime and the thing. Elevation of bed and weight reduction is paramount importance in this. Following that, acid suppression with a PPA or a H2RAs and neutralizing acid with an antacid are important. When LOS support of the thing, you may need to do a manometry to find the road. If that is there, proton matrix can be used for a short term targeting the acid pockets with the RAT technology has also been very useful. Going to hypertension. Any blood pressure over 140/90 is meant to be hypertension. Generally, about 60% of the hypertensives are undiagnosed. BP should be measured at every opportunity possible with the correct cuff in the sitting posture. There have not been much of difference between genders. There are things, many terminologies which are used with hypertension. Resistant hypertension, pseudo-resistant hypertension. Resistant hypertension means more than 3 drugs have not given you a good relief of bringing it down below 140/90. I am using that 140/90 because last month there was a paper which said that except in goals where there is no other complication, you need not go below 130/85. So this has been going up and down every odd year. After James 8, they also lost track of it and left it alone. So last month there was a paper saying that less than 130/85 not to be targeted unless they are of young age and there will be a real utility of reducing it to that level.
What instrument to be used?
I still use I don't use the mercury.
Mercury is gone.
Mercury.
Aneroid
I'm using.
Aneroid is gone now, they say. You should not use aneroid.
You can use microlife or
Use electronic only.
Electronic only. But minus point in India is that there's nobody that is to be calibrated every yearly. We don't have a calibrator here. So some companies did take it up. The electronic ones are to be calibrated yearly, or you need to exchange your machine yearly, which becomes very costly. So an aneroid is still the best option as far as India is concerned.
But even aneroid, they say you after 1 or 2 years you should not use
You can
aneroid.
but then they calibrate. Even Gary Brother calibrates it. What you call the mercury was being calibrated by everybody around. Because of mercury toxicity, it went out. Aneroid there's no real minus point except that it's easier. Anybody can. The home BP becomes why they shifted over to electronic was home BP became much more easier with electronic. Aneroid only a person could do it.
But the American Hypertensive Society is recommending only electronic.
So that is the reason because then only they use it in the home. That is the reason they have said. Specifically it changed because that can be used in the home and all these problems like mass white coat hypertension, mass uncontrolled hypertension are taken off. That is the reason. And the cuff size will be specific to the users in the home, which will not be the same. But unfortunately in India, there's nobody is really doing an calibration. So for us, this thing is better. And I somehow feel, somehow when you use the mercury, still it's available. When you don't use it, you feel much more exactly. Exactly, you feel much more confident.
It's measured as millimeters of mercury, you know.
Yes.
BP is millimeters of mercury. Obviously, mercury
No.
Yeah, lazy to tie it and take it around. That's why we don't do it. Still
So
the
we
gold
wall
standard.
mount, sir.
Still the gold standard.
Wall mounted.
There is white coat hypertension and mass uncontrolled hypertension. When they see a doctor, their BP goes up, that is white coat hypertension. Mass uncontrolled hypertension, when they go home, see their own pose, the BP goes up. The non-dippers are becoming a problem. More obese individuals, more diabetics, the non-dippers are becoming a problem. Night, what happens, most of us don't know. ABP is the only way that can be found out. That is becoming a problem. Refractory hypertension is also becoming a problem because the lifestyle has become very erratic and a lot of people have night calls, duties, those sort of things. So refractory hypertension is becoming another thing. The sympathetic drive is causing the problem. But in hypertension, just like in obesity, what is more important is the risk factors. The risk factor of smoking, family history, dyslipidemia, obesity, the cerebrovascular diseases, congestive heart disease, coronary heart diseases, CKD is much more important because again that is what we are targeting and the presence of that will change your approach. Basically, if there are more than one risk factor, family history or CKD or diabetes or any of those risk factors, even 140 to 150 or 160, 90 to 99, you will start using one drug. When that is not there, at that time you will still try only lifestyle modification. So your approach will be absolutely different, and the drug you use also becomes very different when you have this. Asymptomatic organ damage is something you look for with an ECG for LVH, fundus if possible, carotid wall thickening, not routinely done, whereas there I've taken the Western literature, they say carotid intimal media thickness is a routine measurement there it seems. There, whenever they do an echo, carotid intimal media thickness and for bruise, they routinely measure things. Here we don't get that. And ankle-breaking index is becoming very common. Microalbuminuria strips are available easily. And we need to look at the soft signs because they are also correctable. When you use an ABPM, whenever there's a marked discordance between the office BP and home BP, when you think that these are non-dippers, the LVH is rising though your overall BP is normal. Think of if the situational BP increase in the house or in the work area, or they are non-dippers. Think of that. Suspicion of nocturnal hypertension with absence of dipping. And assessment of BP variability. This has been talked about, multiple scientific literatures are available, but it's still only a research tool, not for the day-to-day usage. Secondary hypertension is a very important thing. Luckily, they are far and few in between, but then they are real headache. I think better referred to an hypertension specialist when that occurs. Routine basic tests are necessary to be documented, let alone for usage or not to be documented, or an hematocrit, plasma glucose, lipid profile, at least a total cholesterol, the sodium, starting sodium value, serum creatinine with the estimated EGFR and urine analysis ECG. These are the minimum. Echocardiograph, other things can be added. Fundus echocardiograph can be added, but these are the basic minimum before starting on a drug we need to document. See, this is the Western literature where they are saying that echocardiography plus Doppler is the commonest available, with the best predictive variability and best reproducibility and cost effectiveness. Where ECG and echo have stood the thing. EGFR, echo and ECG are three things which are almost equal in their thing. So possibly here also availability and affordability is getting better. So unless we correctly diagnose, we target only hypertension. It may not, the adherence and persistence may not be there. Thereby the thing may not work at all. The lifestyle changes are absolutely important. Reduction of salt is very, very important. The known and unknown salt, 5 grams of known salt to be added per person per day. But unknown salt from pickles, poppet, and everything which is in a packet has to be preserved with something. Salt is the cheapest available preservative on earth. So there's a huge amount of salt which goes on. The average Indian takes somewhere around 20 to 30 milligrams of salt. So that needs to be looked at. Weight reduction again everywhere. Right? That's why I put the obesity at the first thing. Weight reduction is very, very important to have any of this chronic disease achievements. Moderation of alcohol, smoking, and regular exercise does really help. Which antihypertensive in whom? See, there were of the 50 randomized controlled trials, of the 58 randomized controlled trials available, 50 were drug comparisons basically. So all the drugs seem to reduce cardiovascular events. That's why Dr. Mani, the famous nephrologist, used to say, use any drug including adelphine acid drugs, you can protect your kidneys and heart. But that said, in special situations like CHF, diuretics are a must, beta blockers are a must, otherwise you are not doing that. Calcium channel blockers are much stronger drugs than other drugs. So, and they were superior in preventing strokes, whereas beta blockers failed in preventing strokes, though they were better for congestive cardiac failure. ACE inhibitor seems to be the good boy all around. That said, they can increase whenever you document the baseline kidney thing. If there's a 30% increase in 3 weeks, you need to stop the drug. You cannot use an AS and ARB together. And also that the potassium is another thing which needs to be measured. If you start with an ACE or ARB today, after 3 weeks there's no increase in creatinine, you are done for the thing unless you are going to increase the dosage. Whereas the potassium can go wrong anytime, so you need to keep monitoring that at least once in 6 months. So how many of our patients will do all that is a problem that we have. That said, they have the best line of defense because they reduce diabetes, they reduce incidence of fibrillation, they have some amount of PPAR effects. So like they tick multiple boxes. The ARBs tick multiple boxes, so they are very good drugs in general. Whereas they have this sort of minus point. CGBs that way are powerful, very easy to use, except for the pedal edema, which a lot of hypertensivists say that it's only cosmetic in nature, you need not be worried about it. That said, the initial listing is generally an ACRB plus or minus an CCB or plus or minus a diuretic. Step 1 in the category 1 with 1 or 2 risk factors up till that 140 to 160, 80 to 90 to 99, that category. After that, you always start with a double drug regime with the ACE or ARB plus a CCB or plus a CB or plus a diuretic, one of the other thing. In patients who fail on initial dual combination, then you can add all these 3. Again, if you can see a blank we are not using beta blockers in this, we are not using any of the centrally acting in this. So baseline drugs are this. Once they cross 3 drugs, they are called as resistant. They are also spironolactone is the choice, 4th choice of drug. Once that fails, then you can try other drugs. The compelling indications are in heart failure, as I said, when beta blocker must be there. In coronary artery disease, it should be there. But stroke prevention and CCB is better, much better. So, in a diabetic, an ACRB will reduce the chance of nephropathy. So, there it is better. But again, remember, ACRB should never be used together. The on-target study clearly said not to be used together. Things which can be used together are diuretics, thiazide diuretics with ACE or calcium channel blockers. Again, you don't use a beta blocker and a thiazide diuretic because both are diabetogenic and both increase tendency. So, like you don't use a combination of ACRB with thiazide and beta blockers. My white coat hypertension I have already alluded to. So the summary is that you may need to start with a 2 pill, you may need to go to even a 3 pill detection and adherence are the key to it.
Combination pills are okay?
Combination pills are very good.
3 in 1 pills are available.
Combination pills are very good. We need to understand only one thing. When you are titrating upwards, use individual pills. Patient also feels that you use 3 pills, you come down to 1 pill after the second or third visit. He's also happy. You also know what is the amount of titration you need. Because all combinations are available with multiple levels of the thing, with multiple milligrams of the thing. So select a combination after you titrate enough. The only minus point with the combination pill is you can't titrate a single drug dosage. But then you can select that level of the thing and give a combination.
Why is it combination pills are not available abroad?
Because 2 things, sir. One, when you are writing only generic drugs, you cannot have combination pills. They are to write only generic names. They are not meant to write trade names. That has been one minus point there. The second thing is that combination pills, when you give it, this sort of problem that you are not titrating it fully. Tomorrow they can go for a case saying that you are not titrated it properly. When we had the step care approach, you go to the maximum dosing of ACE inhibitor, 10 milligram of ramipral, then you go to the next step. That was the approach all along. That cannot be done when you are having a combination pill. So they can put a case on you. Those were the reasons why abroad they don't have it. And again, here also when generic has to be prescribed, I think that will here also will come. Again, we go back. Isolated systolic hemorrhage. Yes, but isolated systolic.
Grow older, they say that.
Still it is there now. Still that, and it's a very relevant. Isolated systolic, isolated diastolic, both are troublesome. Isolated systolic, after the advent of CCBs, to a great extent, we are able to reduce only the systolic, much better, because only on the afferents it works. So, to a great extent, we have one got that. Isolated diastolic is still a problem because whenever you are using any drug including a diuretic or this to reduce the diastolic, along with that systolic also comes down, which is the problem that we are facing.
So after what level is isolated systolic?
Isolated systolic it depends on the pulse pressure. If the pulse pressure is above 60, then you call it an isolated systolic actually. Going on to diabetes, sorry, I will take just 45 minutes. I'll try to close this in 2 or 3 minutes. Diagnosis of diabetes, yes, in a normal person, HbA1c is below 5, fasting is below 99, and 2 hours glucose, or in India 1.5 hours glucose is below 140. Anything above 6.5 is considered to be a diagnostic of diabetes. Fasting of more than 126 or a postprandial of above 200 is considered as a diagnosis of diabetes. In between, we call it the IGT and IFT, impaired fasting glucose and impaired postprandial glucose tolerance, IGT. Yes, anything between 5.7 to 6.4 of HbA1c, or 100 to 125 of fasting, 140 to 200 of postprandial. You need to remember that when you are in this group, you need to do an OGTT of 75 and nitrous glucose, and nitrous is not available, but the difference is very little. So what glucose which is available is good enough to be mixed with 100 ml and to be taken in an empty stomach. If you still don't vomit, then you can continue to do it after 1.5 hours. In India, we use 1.5 hours as a criteria with the same goals.
This instrument need not be calibrated.
No sir, no, nowadays it comes with the thing where you don't need to calibrate, but only life is 5 years.
Other hospital they are doing 2 hours for PPS.
2 hours is what the Western textbook says. We in India consume more of carbohydrate, so our goal should be 1.5 hours. We all know that it affects all the organs. That's why like they used to say for syphilis, now they say diabetes, all the organs. Okay, the basis of management of diabetes is again diet, exercise, medication, and SUV. If you look at it, 2 of the pillars for the thing is given to lifestyle, whereas only 1 is given to medication. Oral antidiabetic agents or oral OHAs, hypoglycemics, or sulfonylureas, which are the most commonly used in India, followed by metformin, AGAs, thiazolidinediones, DPP4 inhibitors, SGLT2s. Injectables could be of either an insulin, which could be rapid acting group or an basal group, or a GLP-1 analog. Coming to metformin, which is the baseline, which ADA just says that to be the first line to be started because it's the cheapest, most commonly available throughout the world, with very little chance of hypoglycemia. That is the reason it was first line. Now this is being questioned because of the advent of SGLT2 and DPP4, which is meant to have more of pleomorphic effects, which is better. But that said, metformin is the cheapest available thing, which also prevents obesity. It's meant to be one-drug. It decreases, it's used in a lot of cancers, it decreases aging, it acts on the ATP, it acts on the cell itself. So it also causes sensitization like your thiazolidinediones. It has got multiple actions, so it's meant to be a one-drug basically. Biggest minus point is G intolerance, which is the reason why many people stop, including irritation, loose stools, bloating, all those things could be there. B12 deficiency has been shown to be not occurring nowadays due to the thing. The only other relative contraindication is in creatinine. But somehow for in all these things, like including hepatic, there was something called as lactic acidosis, which with the pregenitors of other biguanides. So we still hang on to it. Nowadays, US has slowly started accepting that in metformin, lactic acidosis is very rare and in between. So people are opening up. In India, we have been using it through the thing, ICUs and the thing. We have been using it without much of a trouble. Except the nephrologist, nobody says talks about lactic acidosis. Lactic ketoacidosis they do talk about, but then it's more common with SGLT2. The only minus point is you need to reduce the dosage in renal dysfunction. Below 45, you stop using it. Between 60 and 45, you reduce it to half the dosage. below 30 you don't use metformin. Sulfonylureas are the commonest added drugs. Remember, in the adage in medicine, in diabetology is that you only use 50% of the total dosage. Up till 50% of the total dosage, its action will be complementary and linear. Above 50%, it will not be linear and it's not useful. For example, I'm taking, let's say, glimepiride. 8 milligram is the total dosage. But when you go above 4 milligram, it is not as useful. So try to stick to less than 4 milligram generally. So you can use multiple drugs with almost 50% of the dosage, never to the full dosage of any of these drugs, because the side effects will overtake the utility of the drugs. It's the most efficacious of the thing, as good as insulin. 2 HbA1c it can reduce, but on the other side, it can also cause hypoglycemia. This is the only drug where it, because of different mechanisms, not all of them do, but then most of them do, including glimepiride. Over time, the pancreas fails. The so-called OHA failure, it's not OHA failure, it's pancreatic failure, but then the so-called OHA failure was occurring only with sulfonylurea. With none of the other drugs, they occur. To a late, after more than 6 years, it can occur with metformin, but with other drugs, it doesn't seem to occur. The advantage is it's once a day. Many of them have, some of them do not have this sort of minus point of, glibenclamide causes something called as ischemic preconditioning. That is, the heart, as they become ischemic, they give warning signs like palpitation, pain, and all that. The body precondition. Next time there's a insult, it starts informing your brain about all these things. That is lost with things like with drugs like glibenclamide, which is not there with glycoside and glimepiride, which is going to be one of the differences. Weight gain is the minus point of insulin and these drugs. So, now we have quantified it. 3 kgs in 6 months if you gain weight, it negates the achievement of HbA1c. You bring it down from 7 to 6, or you bring it down from 8 to 7, bring them under control, but in the bargain you gain 3 kgs in 6 months. It means that you lost the effect that you have generated with that HbA1c system. And these have a sulfur moiety which can cause reactions like in the rash. These natagalinide and repaglinide are very less used drugs. They are non-sulfonylurea insulin secretory, very short acting. It was, how they promoted was 1 meal, 1 dose, no meal, no dose. These are ultra short acting drugs. Can be given during renal failure, can be given in old age. Hypoglycemia is very minimal. Can be shifted over from sulfonylurea during Ramzan days. This is a very good drug. It's available, not very cheap compared to other sulfonylureas, but then it is very, very useful. Except in hepatic thing, there's a very low incidence of hypoglycemia. These are very good agents basically. They are useful in many situations, but to be used with caution in hepatic dysfunction.
What is the training of
Repa itself is available, sir. 0.5 to 2 milligrams is that. Urepa is available. I use a lot. Old age patients, it works very well. They can take it only just hypoglycemia. They don't come back with hypoglycemia. Very, very useful. No. I nowadays have shifted to a DPP for almost everybody. Like only for the extra cell we use sulfonylurea, where I use this sort of short acting sulfonylurea, which is very good. Ask them to document it throughout the week so that which is the biggest meal, add one non-sulfonylurea, this sort of short acting. Cost the 0.5 starts with somewhere around 6 rupees. Urepas, there are no Curepa, newer and newer drugs which are cheaper are available.
Nobody talks about these drugs in
See, disadvantage is if the fasting is not controlled. You need to use a basal drug. Nowadays we use the other thing, but the postpartum control is very good with these drugs without hypoglycemia. Thiazolidinediones are still one of the best drugs which was marketed under the name of insulin, delay insulin. These are the most powerful drugs, but unfortunately because of congestive cardiac failure, it's earned a bad name. That said, there is a weight gain. As I told you, weight gain is a no-no nowadays, so which is very important thing. There's a LDL elevation, mainly lasts for 1 to 2 months, but then it's the same. The other fact is the thing which just says that in menopausal women, osteoporosis and fractures are a possibility. Cannot be used in macular edema or Graves' ophthalmopathy. These are the only caveats. That said, it can be used during renal dysfunction. It can be used, it is the only drug which is meant to be equally good like saroglitazar. It has an effect on the thing. Only drug which has shown to elevate HDL. No other drug to elevate HDL basically. Only drug which elevates HDL. Which, it deals with, it is synergistic with all other drugs. So it's a great drug, but unfortunately with congestive cardiac failure, sudden this is a problem. Alpha glucosidase inhibitors. In India, I think these are really wonderful drugs because if you can start slow, go slow and reach the maximum they are wonderful because we are all large volume eaters, carbohydrate eaters. This works wonders in the thing. They are quite efficacious. Minus point is you have hypoglycemia with them. You need to use IV glucose and not oral glucose. It may not work in some people. Flatulence and the thing can be overcome if you start low. Glucose has been especially kind compared to the thing. So the maximum amount of scientific literature is available with acarbose. Acarbose is very well decorated, but glucose is very easy to use basically. No weight gain. Except in IBD and cirrhosis, it's very, very easy to use basically.
To be taken along with food.
Along with food, chewed along with food. But now because you have a triple tablet, they say even 10 minutes before, with glucose, very little amount of GRD or disturbance is being seen. The incretin as a concept is very old. It was proposed in 1918 basically. The incretins were also found out by that time, but we could combat it only now. What was found was orally you give glucose, the amount of insulin which rises in the blood was much more robust compared to an IV glucose. So there must be some gut hormone which they said incretin. There are different drugs, there are 17 of them. We just listed a few that are available here. Basically these oral drugs, what they do is that the GAP and GLP, which are the incretin hormones, have a very short life in the blood, which are immediately, it takes around 30 seconds to 1 minute before they are disintegrated. These drugs work on the DPP4 dipeptidyl peptidase enzyme inhibitors. DPP4 enzyme it works on, it makes the life of GLP and GAP longer. So it sustains it longer, thereby it works better. The biggest advantage of this is the pleiomobic mechanism that it works on. It increases insulin secretion according to the amount of glucose that is available. So hypoglycemia is not seen. It decreases glucagon, thereby it decreases the amount of liver hepatic glucose output. Because of the variation in insulin and glucagon secretion, the autonomic neural activity as well as the thing is normalized. It has been shown to increase insulin secretion. It has also shown to decrease islet cell inflammation, thereby regeneration of apoptotic cells are there. Those who are studied only in animal models has not been shown in human models. But that said, there's a lot of possibility it works like that in humans too. It is very tolerable. These are the AEs given when they were released, but we have not seen them in day-to-day. The biggest plus point is they are very synergistic. With other drugs, they have good HbA1c reduction. By themselves, they are very modest or poor HbA1c reduction. Theoretical risk of pancreatitis was talked about, now it is not there. Other three we have not seen. They were costly, they become very cheap in India. SGLT2s are latest golden boys. We are having a tug of war with the cardiologist to take it through between ourselves and them. But that said, these drugs work on the proximal tubule. We all have heard of glycosuria. What we found out was glycosuria does not cause any irritation or any long-term morbidity to the kidneys. Because of that, we understood that that is one route of eliminating sugar. So the glycosygen, which are from the apple tree bark was the thing. These expel the sugar from the urine, through the urine, the proximal tubules. What the kidney usually does is that, like a good spring cleaner, it throws out all the things, takes back what is necessary. In diabetics, what is necessary is accounted slightly higher. 180 is the normal thing. It can go up till 220. So it absorbs more. These drugs bring it down to up till 160, sometimes even 140. So because of that, there is a calorie loss. Because of that, weight reduction occurs. Because the electrolyte, the thing, BP reduction occurs. There is no hypoglycemia because the pancreas is not worked on. Decreases uric acid, decreases triglycerides, decreases OSA by itself. It's independent of its action on the weight. And there's a cardio and renal protection. These are the plus points of this drugs. Cost is still high, though it has come down. Bile acid sequestrants are not used only because you need a large volume of 3.9 grams every time you give 3 to 4 times a day. We also have chloroquine as the thing, as an insulin sensitizer. You know, we're talking about 13 different mechanisms for diabetes, and we have drugs for all this basically. So, only thing is, I'll close by the thing that's saying two more the thing. More important than treating diabetes is doing an SMBG to make them understand that sugar is because they eat, they don't exercise. If they start documenting with an SMBG, saying that today ages it went up, today in exercise it went up, automatically by lifestyle they'll decrease it. No amount of drug can sustain over a long time. Whereas if the patients understand and they use lifestyle to decrease the thing, will have a real good control of diabetes. So SMBG is the sheet anchor of diabetic treatment. Only then they'll understand the utility of your diet and exercise. Thank you. Sorry, I crossed another.
Thank you, Dr. Mohan, for your wonderful, lucid presentation. I think the youngsters who have come here would have really gained your talk. On behalf of independent medical practitioner, a small memento and a check of this 2000.
Thank you, sir. Thank you.